Welcome everyone. It's a pleasure to have everyone back at our next webinar. My name is Shoaib and I'm the course organizer for BitePACES, and we have a really exciting webinar on ophthalmology today. But just before I kick off, I'm gonna, as always, just have a brief run through the course. And as hopefully you guys know, we've been running this course for almost 2 years now. We've had almost 600 people go through the course and several hundred of you tuning into our webinars over the last couple of months. And of course, the webinars are completely free. So please do keep coming along. But for those of you who are interested in the in-person course, we run it in London. We have some really nice patients and we collect data on what's come up in previous exams at previous centers and try and make sure that our patients, are quite representative of what comes up, hopefully, in your exam. We have the 1 day and the 4 day course. Nice patients, small group teaching, and great faculty, in my opinion. And I recognize lots of familiar names in the participant list, some of whom have come on our previous course, which is really nice to see. If you want to find out more about the course, head over to www.bitepaces.com. QR code is there on the top right. If you're not interested in the course and just want to tune into our webinars, just join our WhatsApp group. QR code's there at the bottom right. And yeah, discount code for those of you attending the webinar for the course. So please do make a note of that. We've got some really nice feedback coming through on the courses. So yeah, it'd be really nice to see some of you guys in person. And this is the old webinar schedule here. Our next webinar is on Thursday with Usman, who's our course lead on clinical consultation. So please do keep an eye out for that on the WhatsApp group. But without further ado, I'm going to hand over to Aneesha, who's an ophthalmology registrar. So ophthalmology is one of those things where it's like it very rarely actually comes up. But I think candidates often freak out about it a little bit, understandably, because we get very little exposure to ophthalmology. But what I would advise is don't spend too much time on it. Know the basics of how to use the ophthalmoscope, which Aneesha will go into, and some of the basic cases which will come up, which would likely be, kind of bad diabetic eye disease, pretty bad hypertensive eye disease, and retinitis pigmentosa, and maybe like a really bad optic atrophy. So, it's going to be, if it's going to come up in your exam, it's going to be some really obvious pathology. But if you don't actually know how to use the equipment, then you're not going to see the pathology. So just make sure you're comfortable with at least using the equipment. But without further ado, I'm going to hand over to someone who knows far more about that than I do. So Aneesha, if you take it away.
Thank you. Thanks, Shoaib. Mm-hmm. Am I in full screen mode?
Yeah, perfect.
Yeah, okay. Okay, good morning, everyone. Thanks for tuning in today. So I'm going to be talking about just the basics of fundoscopy. So the fundus, as we call it, is the back of the eye. And I mean, I don't know about you, but at least before I joined ophthalmology, I really struggled to, understand this concept, and I didn't know what I was looking at when I looked at pictures. And it till you actually did it's very vague and abstract. So I'm sure most of you will be going in and out of all your stations with this level of confidence. Unfortunately, when this little person shows up, that confidence can take a nosedive. And it's something that, as Shoaib mentioned, you're not very familiar with. To be honest, you'll find a lot of ophthalmologists as well who aren't very familiar with using this instrument, because I'll tell you why. We don't routinely use it in the ophthalmology clinic anymore, but it still is a very handy instrument. And hopefully by the end of this talk, you'll be coming out of the ophthalmology station or the neurology station with a thumbs up as well. Okay, so what are we going to do today? So just basic things. Okay, first is to look at the ophthalmoscope to identify the different parts of an ophthalmoscope, to understand how to use it, just to get familiar with the technique, because as somebody who's done OSCEs, and done the exams, the half the battle is just conveying to the examiner that you know what you're doing. I mean, it doesn't matter whether you reach the diagnosis or whether you diagnose correctly or not. I think that comes at a later point. The first thing is to just be confident, to know your equipment, to know how to use it. Because if you're fumbling with that, then you've lost it at the start itself. Uh, and it's important to just know what normal looks like, because once you know what normal looks like, then at least it's easier to identify if there is some abnormality. I think they would be very, very cruel if they put a normal patient there and asked you to diagnose something, but you never know. And I mean, what I'd like is, hopefully after this talk, I mean, I know that you're all focused on your exam right now, and possibly, you're never going to use an ophthalmoscope ever again after the exam. But at least if you tried, you might be able to use it in your future, clinical work as well. Okay, so again, you're not doing ophthalmology. I don't think you will ever be doing ophthalmology. So the question that comes to mind is, why do we have to do it? We don't do it on a daily basis. So why do we have to do it for the exam? Is it important? Uh, how many of you here have used an ophthalmoscope before, or, at least handled one? Mm, Okay, I can see one hand raised. That's good. All right. Okay. So, okay, good. So I think we're better off than what I was expecting. So yeah, it's important to use this and to be able to use it, because it's not only ophthalmology. The direct ophthalmoscope is the only non-invasive test. So you're not really hurting the patient, or it's not causing them any pain, and it lets us look at blood vessels and nerves in the body, which I don't think you can do in any other part of the body without, putting the patient through a scanner or doing a biopsy or something like that. Uh, and with this, humble ophthalmoscope, you can sometimes diagnose life-threatening conditions. You can even monitor treatment, and things like raised intracranial pressure, uh, conditions like multiple sclerosis, uh, glaucoma. There are different things that could really change the course of a patient's life if you just picked it up on the ophthalmoscope. So it is an important skill to know. Okay, now, as I said, we need to familiarize ourselves with the ophthalmoscope that I've got here. Uh, I've got the front and the back, or the back and the front. I don't know which way is which. So how many of you think that the image on the left-hand side of the screen is meant to face you? Again, show of hands. Okay. And how many of you think that that's meant, okay, give it a minute. Okay. And how many of you think that that's meant to face the patient? Okay. Okay. Anybody else thinks that this uh the side which says the beta, whatever, is meant to face the patient? Okay, so I think many of you are well versed with the ophthalmoscope, and you'll know correctly that the side on the left hand side of the screen, and you can see I'm holding it up here, just facing you all. This side is meant to face you as the examiner. Okay, it's got a little rest, a brow rest on top, a little window. So basically, the ophthalmoscope, if you have to put it into simple words, it's just a torch and some lenses, and there's a little peephole, and you're shining a light into the patient's eye, looking through the peephole, and those lenses are helping you to get the image in focus. So that's the premise of the ophthalmoscope. I'm not going to go into the physics of it. But yeah, this is the side that should be facing you. Okay. It's important that you know, go to your, clinic or go to the hospital and take an ophthalmoscope in your hand and make sure you identify which side faces you and which side faces the examiner, because that's the first thing that you don't want to do in the exam is to put it on and then be holding it wrong and blinding yourself with the light rather than shining the light into the patient's eye. Okay. So on your side, you've got the brow rest, you've got the little viewing window, uh, and you've got some numbers, okay, over here, and you've got a little wheel on either side, okay. So basically, the wheel has got lenses in, as I said, which helps you to focus the image when you're looking at it. Uh, when you're looking at the patient's eye. The numbers in red are usually minus or negative numbers, and the numbers in green are usually positive or plus powers. Okay. It's advised that you usually start at zero uh, if you are not really short-sighted, or if you don't wear glasses, then you can just take your I mean sorry, if you don't wear glasses, you just start with zero and then you adjust it as and when you're looking at the patient. So the number doesn't really make that much of a difference, so don't focus too much on the number, but it's easier if you start at zero rather than starting at a very high number, because then things will be way out of focus and you'll find it difficult. So if you're starting off, just make sure that the number over there is zero. Uh, there's a little button or a switch here. Sometimes it's green, sometimes it's gray. Okay, so you have to just press it, and then so you press and then you turn. Okay. I'm sorry if this is very basic for some of you. Sorry if I'm teaching some of you to suck eggs, but I just thought it's good to just go through the instrument. So you and as you're turning, okay, the light gets brighter and brighter. So you don't have to turn it all the way around to put it on. Even if you turn it a little bit, it still is on. But it depends on how bright you want it. If it's very bright, so it's always better to start off with a lower brightness, and then if the patient is, managing the brightness well, then you can keep dialing to a higher level. But if you start off with the brightest setting, you're going to dazzle the patient and they're going to be uncomfortable and they're going to close their eyes. And the last thing you want is your patient being uncomfortable and uncooperative. Okay. Now we come to the right hand side of this slide, which is the patient side. So this is what the patient side would look like. Okay, so again, it's got the viewing window, the same window that you are looking through on this side. Obviously, the light goes through into the patient's eye. Okay, and then different instruments can have things slightly different, but there are basically two things over here. There is an aperture and there is a filter setting. Okay, so the aperture wheel, as you can see, has got different settings. So you can have uh, a grid setting, you can have a big circle, a small circle, uh, a really so the big, the medium, and the small circle. Then you can have a slit of light and you can have just a half circle. Okay, so the one on top controls the shape or the size of the light that's coming out of the aperture, and the little lever at the bottom controls the color of the light. So again, as I said, it depends on the model that you've got. This can be slightly different in different instruments, but basically you're doing the same thing. You're choosing what size of the light you want, and you're choosing what color of the light you want. Okay, so in terms of size, uh, if your patient is dilated with dilating drops, then you can go for the biggest circle. If they are not dilated and the pupil is a bit smaller, then you would choose one of the smaller circles. Okay, you would choose either if it's a dark room, then the pupil tends to be a little bigger. So then you would choose the middle, the circle. And if the pupil's really tiny and the light is, you can't darken the room, then you would choose the smallest aperture, which would go through the small pupil. The slit is more for, just seeing the thickness of things, or just seeing the cornea. We don't really use it that much. And again, the half circle is if you have some opacities and you want to, you don't want the light just reflecting off it. So supposing there's an opacity in the top half of the cornea, you use the semicircle and you go underneath it. Okay. Uh, in terms of the color, so in this one, you've just got the green and the white. The green is what we call the red free. Okay, the green light is, just show it to you here. So the green light is what we call the red free. The red free is actually used to see things that are red. So things like blood vessels, or things like hemorrhages, they would appear dark black on the red free, and they are highlighted better. So if you want to look say in a diabetic patient, you want to look at microaneurysms or dot hemorrhages, the red free light is more useful for that. In some ophthalmoscopes, you can also have a blue light. This one seems to be a snazzy new one, and doesn't have a blue light in it. But the blue light is mainly, for the cornea. If you've got a corneal abrasion or an ulcer and you put fluorescein drops in, you can just use the blue light to highlight the fluorescein, but we don't really use the blue light to look into the eye. I'm not Okay. So, yeah, sorry, I was just looking at the messages. I'm not very good at looking at the messages while I'm talking. So if there's anything that is, very pressing, then maybe just kind of raise your hand and let me know what you want to ask. Or if not, I can take questions at the end of the talk. But yeah, so the simple way to remember it is when you put it on, okay, whichever side the light is, going in, that side goes to the patient. Okay, don't do that. It's quite bright, and it is uncomfortable. So if we've identified the sides of the ophthalmoscope, you can actually take the head off. I don't think they'll be asking you to attach the head in the exam. I think you'll have it, in this way. But in case if you do see it, so this one's new and a little bit tight, so I don't want to. But in case if you do see this part and this part separate, all you have to do is just, click them together, and it fits in quite well, because sometimes they do that. You can use different heads. Okay, so moving on. Okay, so just to be clear, that's the examiner side, that's the patient side. Did anybody have any questions regarding the parts of the ophthalmoscope and the sides, or what we use? I shall take silence as as meaning no questions. Yeah, okay. Okay. So, yeah. The other thing I wanted to just say is, how do you hold the ophthalmoscope? Okay. Ideally, don't hold it just like that. Okay. Get into the habit of holding it like this. Okay. So you wrap your thumb and these three fingers around it, around the body of the ophthalmoscope, but keep your index finger on the wheel there, okay? So that it's easy to adjust the focus while you're looking at the patient's eye. Because if you hold it that way and then you're looking into the patient's eye, and then you want to, change the focus, then you are at that moment you're scrambling for the wheel, and it just you're wasting time and it looks very clumsy. So get into the habit of holding it like that. Yeah. So that's how you would hold it for your right hand, and that's how you would hold it for your left hand. Okay. So yeah, just a few steps on how to do it. Uh, so it's always better, at least initially, to have your patients dilated. I think Shoaib said your patients are dilated in the exam. Uh, but sometimes, yeah, if the pupil is smaller, you just use the smaller aperture. Since your patients are dilated, I would recommend just using the biggest circle for the exam, uh, usually dilated with tropicamide drops. Again, uh, before you start approaching the patient, make sure your light is shining and it's bright. Sometimes if the ophthalmoscope has lost charge, it can, or if the bulb is fused, it just won't come on. And yeah, so that's not a situation, again, you want to be in. So before you approach the patient, put it on, check it on your hand that the light is working, okay? And as I said, set the power to 0. Again, not too sure if you all can see, but in there's a little, uh, number that you can see. And as you dial the lens, the numbers keep changing. The red means minus and the green means plus, okay? So we go to 0, okay? Now, you make sure that the patient is comfortable, okay? Ideally, the patient should be sitting down. And it's also important that you are comfortable, okay? Remember that the examination does take a little bit of time. So if you are not at the same height as the patient, you're going to be bending, you're going to be very uncomfortable. So either sit at the patient's height level, or if they're sitting, ask them to kind of sit with their back straight up so that they're at your level, maybe looking up a little bit if you're standing. Uh, and yeah, just think about the difference in the height before you start your examination. You want to be, uh, sat across them. Ideally, you don't. I wouldn't. If you are sitting in front of them, I wouldn't advise sitting bang in front of them. Maybe you kind of sit with your shoulder, uh, just adjacent to their shoulder. So your right shoulder and their right shoulder in a line. Okay. Now, before you do the examination, obviously you've sanitized your hands and everything, but explain to the patient what you're going to be doing. Because remember, you're going to be, possibly dimming the lights and going really close to the patient. So you don't want a GMC charge on you for doing something which, the patient thinks, I don't know. Uh, so tell the patient that you're going to be dimming the lights, you're going to be shining a light in their eye. The light can be a bit bright, and that you're going to be coming very close to the patient. So this is one of the examinations where you do get quite up close and personal with the patient. So make sure you inform them and take their consent that, verbally, that they're okay with it. Um, you can remove your spectacles and ask the patient, obviously, to remove theirs. Uh, However, if you've got a very high prescription, or if the patient has a very high prescription, sometimes it can be easier to just leave it on. But again, I think for the purposes of the exam, it's unlikely that they're going to be giving you a patient who's got a very, very high prescription. So just ask the patient to remove their spectacles. When you do it, I mean, it's up to you. You can take off your glasses or you can keep them on, whatever you're comfortable with. But just remember that the lens power that you dial in depends on what your refractive power is and what the patient's refractive power is. All right. And then you turn the room lights off. And the key thing to remember when you're doing the ophthalmoscopy is that when you are examining the right eye of the patient, you are using your right eye and you're holding the ophthalmoscope in your right hand. Okay, this is very important. I cannot stress enough how important this is, because if you try to examine the left eye of the patient with your right eye and holding the ophthalmoscope in your right hand, you might end up getting a slap from the patient. If you don't understand why, just go and try it out with a friend, and you'll figure out how awkward and uncomfortable it can be if you don't follow this rule. Okay, so just remember, right eye of the patient, your right eye and your right hand, left eye of the patient, your left eye, your left hand. Okay. Okay. So before we go any further, this is a picture of a normal fundus. Is this the right eye or the left eye? How many of you say left eye? Just raise your hands. Okay, anybody else for left eye? This is the best time to make all the mistakes, remember. Because at least for me, whenever I make a mistake, it's then etched in my memory. So I'd rather have it the right thing etched in my memory. So yeah. Anyone for the left eye? Okay, how about the right eye? Okay, yep, you guys are good. So yes, this is the right eye. Okay, if you struggle to remember, it's not easy. As I said, when I was in medical school, and if I looked at these pictures, I had no clue what I was looking at. Okay, so I've got a little you know model of the eye here. So this is a cross section of the eye, okay? And basically what you're looking at is this part, you're looking at it, on face. So this is what you're looking at. So yes, so remember the optic nerve is towards the nose, okay? So the nerve is nasal, okay? So if you just imagine two eyes, so that's if you imagine the patient sitting in front of you, and if this is the right eye of the patient and that's the left eye of the patient, the optic nerves are usually somewhere here and somewhere here. I hope you can see my pointer. You just give me a thumbs up if you can, or raise your hand if you can. Can you see my, yep, okay, good. Yeah, so the optic nerve is somewhere here for the right eye and somewhere here for the left eye, okay? Again, it's useful to just remember this, map when you have a mental picture of it in your mind before you start, because what happens is sometimes it's very easy to just get lost when you're doing the ophthalmoscopy. I'll explain a bit later. Okay. So now that we know how to hold the ophthalmoscope, okay, so we're holding it, with this side facing the patient. We start off with actually doing the ophthalmoscopy. So initially, your aim is to try and get to the optic nerve, okay, because that's an easily identifiable landmark in the fundus. So now, since the nerve is nasal, okay, or medial, you want to go laterally because you're then moving in that direction, okay? If you start nasal and then you move this way, you end up actually going away from the nerve, okay? So that's why you usually stand at the side of the patient, about 15 degrees to the side of the patient. You ask the patient to look at something far away, okay? Just give them a target. Don't just say look away. Give them a target. Say, can you look at the hand sanitizer, or can you look at the light switch or something? It's easier for them to actually focus on something rather than just saying, can you please look in the distance? Looking at the distance, kind of negates the accommodation. So just in case the drops have started to wear off, at least the pupil then still remains a little bit larger if you are asking the patient to look away. Okay. The other advantage of standing a little to the side is that you're not coming in the patient's line of sight, and so they can maintain their fixation at the distant target. Okay. So the first thing you do is you are standing about half a meter away, an arm's length away from the patient. You've put your light on, you're asking the patient to look in the distance, and then you just shine the light into the pupil. All right. And that's when you see the red reflex. Okay. So this step is what we call a distant direct ophthalmoscopy, because obviously you're doing it from a little bit of a distance. You're not coming straight into the patient, close to the patient. After you've done that, then you keep the ophthalmoscope there, and then you slowly start moving towards the patient as this person in the picture is doing so. You can keep your other hand either on the patient's shoulder or on the patient's forehead, whichever is comfortable for you and the patient. But again, explain to the patient what you're doing, because otherwise they will get nervous and they will not cooperate with you. Okay, so you start off with A, which is just looking at the red reflex, what we call as a distant direct ophthalmoscopy, and then you move in closer, keeping your eyes fixed on that red reflex, and then you come close to the patient as in C, and that's the actual direct ophthalmoscopy being done. Okay. So why do we do distant direct ophthalmoscopy? It's a good screening. It's a very quick screening. It's actually a very useful thing that you can use to examine children, to examine uncooperative patients, because basically what happens is, again, if you look at the eye, from the side, if you look at a cross section of the eye, you know that the light is going through the cornea, in through your pupil, into the lens, into the vitreous, and then hitting the retina, and then from there going into the nerve and going back into the brain. So if there is any opacity in any of these structures, or if there is any pathology in any of these structures, that light that you are shining from your ophthalmoscope gets blocked. And then you, instead of seeing a nice red circle, a red reflex, you then start seeing shadows or a whitish reflex instead of a red one. Okay, so just doing the distant direct ophthalmoscopy, which hardly takes maybe 2 or 3 seconds, just shining the light into the patient's eye, you can diagnose corneal opacities, that you can see if there is blood or pus in the anterior chamber, cataract, vitreous hemorrhage, that is hemorrhage in this part of the eye. You can see if there's a retinal detachment. A very important thing for children, under 2 especially, is that very rarely they could have a retinoblastoma. And as you know, this is a life-threatening condition, and it can be picked up with just this simple ophthalmoscope, and you could save a child's life if you refer them in time. So that's something very important. The other thing is that if somebody has a very high plus or a minus power in their glasses, the reflex that you will get will not be a bright red one. And again, then you can refer the patient on to the optometrist for getting glasses. Okay, so I've just got some images here. So the one on the top left, this is what a normal red reflex looks like. So when you're shining the light into the patient's eye from about, half a meter away, or an arm's length away, you should rather see the first image, the image on the top left. Okay, so that tells you that there are no media opacities. The light that you're putting into the eye is reflecting off the nice red orange retina and coming back, and so no media opacities, everything is good, clean, healthy. The one here, these grayish shadows, or these opacities over here, and this one over here, they're basically different types of cataract that you see. So these are opacities in the lens, and that's why they're blocking the light going through. Okay, This here is what we call leukocoria, or a white reflex, okay? As you can see, it's quite different from the red reflex. So when you're shining the light in, there is something at the back of the eye which is not letting the right light be reflected. It could either be a tumor, or it could be a retinal detachment, or it could be an old hemorrhage. But any which way, if you see this, especially in a child, you should be referring that patient on to the ophthalmologist immediately. Yeah, so that's something that you can pick up in literally 2 seconds with the patient. So it's something important to know. Okay, so now that we've done the direct ophthalmoscope, or the distant direct, we follow the red reflex. So we're not taking our eyes off the pupil. We've not, not done that. You're still got the ophthalmoscope there, and then you're going in, approaching the patient. And then as you approach the patient, you get closer, you use this wheel, okay, to get things into focus. You will start seeing either blood vessels, or you'll start seeing the disc. So whatever you see, just get that into focus, and then have a look at it, see if there's any abnormality over there. In the blood vessels, the veins are usually darker and thicker than the arteries. The arteries are a brighter red, and the veins are usually a maroon, or a deeper red, darker red. You then kind of follow the vessels along and look at the optic disc, which is basically the front section of the optic nerve. And after you've had a look at the disc, evaluated the disc, you then move, slightly laterally or temporally to look at the macula, which is the important part of the retina, basically the most sensitive part of the retina that we use for fine focus. Uh, the macula is usually about 2 disc diameters away from the disc. So when you're looking at the disc, you can say you're looking at the patient's right eye. Okay, you're looking at the disc. You can either move yourself slightly, so just pivot slightly towards the lateral side, or you can stay where you are and just ask the patient to look at the light. So they were looking far in the distance all this time, but then now you tell them, please, can you look at the light? So the minute they turn towards the light, they turn their eyes towards the light, the macula will come into focus, because that's the part of the eye that we use for focusing. Okay. Yeah, just a word of advice: don't keep shining the light on the macula for a long time. Be quick in your examination, because it can be quite painful, the light on your macula for too long. Okay, so this is a picture of the left eye. Okay. This is just normal. I've just kind of labeled things there for you to know what. So it's always important to know what normal looks like. So this over here, that's what we call the optic disc. Okay. Within the optic disc, you'll notice there's a smaller circular paler area, what we call the optic cup. Okay. Then from the disc, you'll see the vessels kind of emanating out. As I said, the arteries are lighter in color, and the veins are darker in color, and usually slightly broader or thicker than the arteries. Then, as I said, the nerve is nasal. You come temporal or laterally, about 2 times the disc diameter, and then you are at the macula. So the macula is like a slightly darker area in the central part of the retina, and the fovea is at the center of the macula. All right. So now we know how to use the ophthalmoscope. We know what we're looking for. So we're off and we're looking into the patient's eye, and that's what you see. And now you're a bit confused, because you were expecting to see this when you looked into the eye, but what you're actually seeing is this, and it doesn't make any sense at all. And that's why many people don't like the direct ophthalmoscope. In fact, that's why it's kind of fallen out of favor with ophthalmologists as well. So the reason that you only see that is because the ophthalmoscope, the direct ophthalmoscope, is only giving you a 10-degree field of vision. So you're only seeing a tiny bit of the eye at a time, okay? And it's quite magnified, okay? So there's a 15-fold magnification. So you're seeing a little bit of the retina and you're seeing it really magnified, okay? It's called a direct ophthalmoscope. Again, I think for you'll just call it an ophthalmoscope, but an ophthalmologist will call it a direct ophthalmoscope because, as I've written there, the image that you see, again, this is more just theoretical. I don't think it's important for you, but it's just a little interesting bit of information. The direct ophthalmoscope, the image is upright. So it is as you see it, all right? But there are other ophthalmoscopes. So there is what we call as an indirect ophthalmoscope, or sometimes you might have seen us using some lenses. So when we do that, basically the image is inverted. So it's upside down and turned left to right. So thankfully, you don't have that in your examination. You just have the direct ophthalmoscope. So it's simple. What you see is what is there. If you see something on the top, that means it's on the top of the eye. If you see something at the bottom, it's at the bottom of the eye. Okay, so yeah. But yeah, as I said, you're just seeing a very tiny bit of the retina, and hence what you see when you look through the ophthalmoscope is actually just this instead of this big picture. And that's why many of us, get confused. We get lost when we're doing it. We don't know where we are. We don't know what we're looking at. Everything just looks pink. So, as I said, the main thing to remember is just try to, whatever comes into view, just try to focus it, okay? Because most of the time, there will be at least one blood vessel in your field of view, okay? So just look at the blood vessel, okay? That's there. Just look at it and then just dial this in whichever way. So first dial it in one direction, see if it's getting better or worse. If there's nothing happening, then dial it in the other direction, okay? Don't do that, okay? Just go systematically one click at a time, okay? Don't be in a hurry to just focus it. Go one click at a time and go in a systematic manner. So once you have focused on the blood vessels, all right, once you've got a crisp image of a blood vessel, just remember that the V's of the blood vessel, okay, always point towards the optic disc, okay? So that's what I mean by the V's of the blood vessel. So if there are any bifurcations of the blood vessels, if there's a V, just think of it as a little arrow that's pointing you to the direction of the optic disc. So focus first on a blood vessel and then start moving your so you just have to kind of pivot and move towards the optic disc, okay? Once you're at the disc, there are 3 C's that you need to look at. You need to look at the color of the disc, which is normally a pinkish, yellowish color. You look at the contour of the disc. That means the outline of the circle. It should usually be a smooth and well-defined outline. Okay. If it is ill-defined, then it could be a sign of optic disc swelling, which we will see a bit later. And then you look at the optic cup. As I explained to you earlier, the outer pink, so there's an outer like a pink donut, and in the middle, there's a pale yellow circle. So the pale yellow circle is, so you can see there's an outer pinkish donut. So that's basically the nerve fibers. And then there's a little yellow circle, which is, where the nerve fibers are exiting from the eye. Okay. So this is known as the cup, and the purple circle is the optic disc. Again, imaginary, you have to think of a vertical diameter, okay? And then you usually think of the ratio that the red diameter is to the purple diameter, okay? So it's usually about a third or 1/4 of the entire. So the cup is usually a third to half of the entire disc. If it is more than that, then it can be a sign of glaucoma. All right. So about that much is normal. Okay. But if you see very, if you see a lot of cup and not much of the disc around it, then that's a sign of glaucoma, advanced glaucoma. Okay, sometimes, and you might actually see these patients in A&E before us actually. So if a patient has ill-defined, so here you can't really see where the border of the disc is, and you can see that there are lots of hemorrhages on the disc. Okay, and again the similar thing over here. You can't really see the outline, right? There's no contour that you can make out, and sometimes you can actually feel the disc popping out towards you. Okay, so that's in disc swelling. The direct ophthalmoscope is not very good for 3D view because you're only using one eye, so there's not much stereopsis. But sometimes if it is very marked, you can make out that the disc is actually, coming towards you. The nerve is swollen towards you. Okay, so papilledema is bilateral optic disc swelling. It's seen in raised intracranial pressure and malignant hypertension. So if you see an image like this, I think the first thing you should do is measure the patient's blood pressure, because obviously that's the easiest thing that you can do. And then you would want to scan this patient just to make sure that there are no space-occupying lesions or bleeds in the brain. And as I said, it can be life-threatening, so it's important that you should at least have a vague idea of what it looks like, because obviously these patients present to A&E and you see them before us. So this is what a patient with papilledema would look like. You can see that, so this is still, the early stages over here. So hence the disc is still a bit pink, and you can vaguely make out the margins, but you can obviously see that it's a bit blurred and you have this appearance. So that's a disc swelling. Sometimes you can have hemorrhage just at the disc. In some patients, in normal situations, you can see pulsations in these blood vessels, all right? But I think in about 30% of patients, in normal people, you don't have pulsations. So if you don't see pulsations, it doesn't mean that there is papilledema. But if you do see pulsations of the blood vessels, it's less likely that the nerve is, really swollen, and it could be that there's something else going on. But again, I don't think that much would be expected from you, just identifying that the disc, the margins are blurred and it's swollen. Okay, so now we've looked at the disc. I'm just going to quickly run through some of the other pathologies that you could see in the rest of the fundus. So you can see whitish, yellowish white, fluffy kind of exudates. They used to be called soft exudates because that's what they look like, fluffy white things. So they're called cotton wool spots, and they're seen in any ischemic condition. So it's basically ischemia of the axons which cause that whitish appearance. Then you can have retinal hemorrhages. You can have hemorrhages in multiple layers. The deeper layers, usually you have dot hemorrhages, and the more superficial layers, you have the flame-shaped. So this here is what we call a flame-shaped hemorrhage because it's following the nerve and hence the appearance of the hemorrhage. But the deeper layers, you have more just dot and blot hemorrhages. Sometimes you can have bigger hemorrhages. Again, you can see this in hypertensive patients, in diabetic patients, sickle cell. Sometimes even if the patient's just really, lifted something very heavy, you can get this kind of an appearance. Okay, then moving on to, I've just kind of grouped things that look similar because they can be a bit confusing. So you can have hard exudates, which we normally see in diabetic patients. And you can have drusen, which you normally would see in age-related macular degeneration. Unfortunately, a lot of old people also have diabetes, so you could see both of them together. But again, I think for the purposes of the exam, they would just have one rather than the other. Hard exudates are usually, better defined, and sometimes they can have a little refractile nature or a little shine to them. Drusen and hard exudates are usually a bit more superficial. So sometimes they can obstruct the blood vessels, whereas drusen are usually deeper in the retina. So that's why the blood vessels are usually going over them. So drusen don't usually obstruct a blood vessel. You can see the blood vessels are going very well over these lesions. They're little yellowish circular lesions. And drusen are sometimes a little bit bigger than hard exudates. As I said, hard exudates are seen in diabetics, in patients sometimes with high blood pressure. So you'll also have some other signs of diabetic retinopathy or hypertensive retinopathy, like some hemorrhages, or you can have microaneurysms or cotton wool spots. So those are, indicators that these are hard exudates and this is diabetic retinopathy rather than drusen and age-related macular degeneration. Again, this is a choroidal neovascular membrane, which is seen in age-related macular degeneration. Very, very, very common in the UK. The NHS is spending lots and lots of money treating these patients. I think the second highest cost to the NHS is injections for these patients because there's so many of them. So you'll see like a yellowish, well-defined or sometimes a little poorly defined lesion, and there can be some hemorrhages. The thing with the age-related macular degeneration, as the name suggests, is it's usually restricted to the macula and you won't have changes in the rest of the periphery. So if you see something that is mainly focused at the macula and very commonly in both eyes, then that's age-related macular degeneration or a choroidal neovascular membrane. You could see a retinal detachment. Unlikely that they would keep that for you in the exam because it's not something that you diagnose with a direct ophthalmoscope. But if a patient had a detachment and you looked into their eye with a direct ophthalmoscope, you might see a kind of a whitish shadow overhanging, or you may see these kind of folds of the retina. It looks like, a little flap kind of billowing over there. So that's a retinal detachment. You might see a macular hole. Again, not something I think they would keep for you in the exam, but that's what, again, these are things that you would see with a direct ophthalmoscope. Yeah, I remember when I first saw this, I thought of somebody taking a cigarette and, burning the paper. That's the kind of image that you get, at least when you look at it through a direct ophthalmoscope. Okay. Shoaib mentioned that sometimes you can get retinitis pigmentosa in the exam. And I was just thinking of things that look like retinitis pigmentosa that you might also have in your exam. So if you have a diabetic patient, okay, some of the diabetic patients could have had laser, okay. If they've recently had laser in just the past few days, then the laser marks will look like these white big spots, and you'll not confuse it with the hard exudates or drusen because these spots are usually in the periphery. They're circular spots. They're in a pattern. They're usually in a grid pattern. So you can make out that, it's something that's been done intentionally. And over time, the laser then appears like these scars, okay? But again, if you look at these laser scars, they are well defined. They have, almost equal spacing between them. And then you can also see the other signs of diabetic retinopathy over here. So that's your clue that these are laser scars. These are not, the bony spicules of retinitis pigmentosa. So this is the picture at the bottom is what retinitis pigmentosa would look like, the periphery, and this is what laser would look like. Again, I've just put it there because sometimes you could get confused between the two, especially if you're not used to seeing these patients very often. And if they do put patients of diabetic retinopathy and retinitis pigmentosa, you could get confused between the two. Okay, so just going to quickly run through, conscious of the time as well. Quickly going to just run through some common conditions that you all might get in the exam, what it looks like, just a picture of what it looks like. Okay, so that is what diabetic retinopathy would look like. The picture on this side here is what we call as non-proliferative diabetic retinopathy, and the picture on this side here is proliferative diabetic retinopathy. So the left is the worst one. The picture on the left side is the worst one, and because it's proliferative, which means that new blood vessels have started forming because the eye is so ischemic. So again, when you look at it through the ophthalmoscope, you will see these fine little, uh, you know, blood vessels that look like little tiny rice noodles or hair, which are red in color. So you just see little tufts of blood vessels, very commonly at the disc. Okay, and if you see this, very often these patients at least would have had some laser as well. So if that's also a clue for you. Obviously, you'd have some history possibly, to ask the patient whether they're diabetic, how many years they've had diabetes, is the diabetes poorly controlled or well controlled. All these factors play a role in the progression of diabetic retinopathy. And on this side here, on the right hand side picture, you see the non-proliferative. So this is like an earlier stage of the diabetic retinopathy. So you can see there are no new blood vessels, but you can see hard exudates at the macula. You can see microaneurysms and dot and blot hemorrhages. It's really difficult to differentiate between the two, between a microaneurysm and a hemorrhage, but microaneurysms are usually tinier than the dot and blot hemorrhages. But as I said, for exam purposes, I don't think somebody's going to ask you, is that a microaneurysm or is that a dot hemorrhage? And as long as you get diabetic retinopathy, that's fine. And remember, microaneurysms are characteristic of diabetic retinopathy. So if you see these tiny red dots at the macula and there are hard exudates along with it, then sometimes cotton wool spots as well, then you should be thinking about diabetic retinopathy. Diabetic retinopathy is usually seen in both eyes. It can be asymmetrical. It can be worse in one eye compared to the other, but it usually affects both eyes together. Then you have a vein occlusion. These are just common pathologies that we see. So I'm just going through them. You can have a branch retinal vein occlusion, which is basically you see one quadrant of the retina. So most commonly the superior temporal quadrant. You just see lots of hemorrhages. You can see some cotton wool spots, but it's just like lots of hemorrhages there. So if it's in one quadrant alone, then it's called a branch retinal vein occlusion. And if it's in all quadrants, then it's a central retinal vein occlusion. Again, this I think many of you might have already seen, a cherry red spot that we see in central retinal artery occlusion. So this part over here, the cherry actually is the normal retina that you are seeing, because the rest of the retina is basically there's ischemia, and so there's axonal swelling, and hence it's whitish and blocking out the red reflex. So hence you get the cherry red spot. Seen in central retinal artery occlusion. Sometimes you could see the embolus, but sometimes you might not. Can also be seen in giant cell arteritis. Then coming to hypertensive retinopathy, again, there are different grades. I don't think they will expect that from you. But with hypertensive retinopathy, you just need to kind of look at the blood vessels, look at the optic disc. Okay, so in the blood vessels, very classically, you would see the AV nicking. So in a normal AV crossing, you can see that, that's what it looks like. But in hypertensive retinopathy, because the artery and the vein, they share a common sheath, adventitious sheath, when the pressure in the artery is high, it kind of presses on the vein, and that's why you get this kind of appearance over here. and that's very classical of hypertensive retinopathy. You can see cotton wool spots, which means it's obviously worse, and malignant hypertension or grade 4 hypertensive retinopathy, you'll see disc swelling. So as I said, if you see disc swelling in both eyes, the first thing you want to do is check the blood pressure to rule that out, because it's the easiest thing that you can do. Optic atrophy. So as I said earlier, the optic disc usually appears pinkish or a yellowish, more pink in color. In optic atrophy, it can appear chalky white. So it really looks pale, and with the ophthalmoscope, it kind of just it reflects the light really well back. So if you look at the disc and if it's looking very pale, think of optic atrophy. Sometimes you can have other things in the fundus that would contribute to the optic atrophy, like in a case of retinitis pigmentosa or a case of diabetes. Or it could just be that there's only optic atrophy there because of some underlying optic nerve pathology. Okay, and we looked at optic disc swelling before. As I said, if it's in both eyes, then we call it papilledema. If it's in one eye, we usually just call it as optic disc swelling, which, as I said, is basically blurring of the margins. The disc appears very hyperemic, very red. You can have hemorrhages. The vessels will be engorged and, really very, very prominent. And sometimes in optic neuritis, if you move to the macula, you can see that there are exudates in the macula in a star-like pattern, what we call as a macular star. But this is not very commonly seen in acute conditions. In acute pathology, it's mostly just the nerve that is involved. The macular star comes later on down the line. I've just put a picture there of retinitis pigmentosa because Shoaib mentioned that you can get this as one of the conditions in the exam. In a patient of retinitis pigmentosa, obviously they complain about night blindness. There may be a family history of the condition. And there are 3 things to look at in the fundus. Okay, so the first thing is that the optic disc will be pale. All right, so there's optic disc pallor. The second thing is the arteries will be very attenuated. So over here in this picture, you can see you really have to struggle to look at the arteries to find them. In some places, you can't even see where the arteries are. So the arteries will be really attenuated. Okay. And the third thing is the bony spicules. Okay. So that's the triad of retinitis pigmentosa: the optic disc pallor, the arteriolar attenuation, and the bony spicules that you see in the mid periphery. Okay, so to look at these bony spicules, you will have to turn your ophthalmoscope. You'll have to look up, look down, and or ask the patient to look up or look down. But in my experience, it's easier for you to pivot up and down and just ask the patient to keep looking straight rather than asking them to look up and down. But practice with a patient and see what suits you better. Yeah. So just a quick recap. I know I've been talking for a long time. Hope you all aren't gone to sleep by now. Just remember, right eye of the patient, your right eye and your right hand. First, look for the red reflex. It will give you a lot of useful information. When you go in, look for a blood vessel. Look to see if there are any changes in the blood vessel or around it, and then use that blood vessel to point you towards the optic disc. Sometimes you might just end up on the disc right away. Okay, but even the disc has blood vessels. So always look at the blood vessel and focus, get those blood vessels into focus, and then you're good to go. Remember the 3 C's of the optic disc. That's the color, the contour, and the cup. Look at the macula to look for any hemorrhages, look for exudates. For patients of diabetic retinopathy, hypertensive retinopathy, and look for drusen or neovascular membranes for age-related macular degeneration. And after you've looked at the macula, then you look at the periphery. It's always good to go in a systematic manner. So if you are looking at the periphery, choose which quadrant you want to do, and then, go. So either if you go superior temporal, superior nasal, inferior temporal, then you move to the other eye. Don't, go up and down and here and there, because one is you will get lost. You will not know where you are. You will get confused, and you will irritate your patient because you'll be taking longer time, and then they will not cooperate. And remember, that patient has been examined by somebody before you as well. So they're already not in a very good mood. Okay, so my only message to you is go find an ophthalmoscope, put it on, get it in your hand, feel how it is, and just practice. It's really easy. I think people just are scared about it because they've not used it that often, but it's not a difficult instrument to master. Thank you. Any questions? I'm happy to take them now. So which one should we use for the exam? Which hole size? I think I answered that. If your patient is dilated, just go for the biggest circle over there. How does the cherry red spot occur? Yes, as I said, basically because of the ischemia. So there's a blockage in the artery, there's ischemia in the nerves, and because of the ischemia, there's axonal swelling, and the nerve, which is normally transparent, then becomes opaque because of that ischemia. In the fovea, you don't have the nerve fiber layer, because that's the very thin part of the retina. So you don't have the nerve fiber layer over there. So it's actually the rest of the retina has gotten opaque. Just that bit is not opaque. Hence, you can see the red uh, retina behind through that little bit that's not opaque, and the rest of it that is opaque is kind of blocked out the red reflex. Does that make sense? Can you put some light on angioid streaks? Uh, okay. So angioid streaks are basically uh, cracks that you would see in the choroid. So you have the retina, and underneath the retina you have the choroid, and between the two you have the Brooks membrane. Uh, I think there's a mnemonic, which is Pepsi, for the causes of angioid streaks. I will have to look it up for the actual full form of the uh, thing. But so it's basically, if you look at the optic disc, and from the disc, if you see kind of things that literally look like cracks emanating from the optic disc, uh, that would be angioid streaks. Again, I'm not too sure whether they would put that for you in the exam, because it's a little bit of advanced case to expect you all to examine. But yeah, I think the mnemonic is Pepsi, which is pseudoxanthoma elasticum, Ehlers-Danlos syndrome, Paget's. S is I'm struggling with S and I. Sorry, you'll have to look that up. Does that answer your question a little bit? Oh, okay. Yeah, I mean, if you give me a second, I can just very quickly get you a picture of angioid streaks, and uh, yeah, I'm not yeah, I'm not here yet. Yeah, sorry, somebody wanted a consult. Hey. Hey. If there are any other questions in the meantime, if you can ask me, like I'm just getting this. Just getting a picture for you all. So yeah, the Pepsi mnemonic was pseudoxanthoma elasticum, Ehlers-Danlos, as I said, Paget's, sickle cell, and I was idiopathic. Can you see the picture? Sorry, I just had to take the first one I found. Just raise your hand if you all can see it. Yep, okay, good. So yeah, this is basically what angioid streaks would look like. Again, it is something as that you would be able to diagnose with the direct ophthalmoscope. So the thing about the direct ophthalmoscope is that it's useful for looking at things that are at the disc and the macula, just at the central part of the eye. So if there are conditions which focus on the central part, then yes, it is likely that you could possibly get a patient, like that. So basically what happens is that the choroid, which is underneath the retina, has got the elastic fibers, uh, which are abnormal, and hence the Brooks membrane develops these cracks. So if you are looking at the patient, you're looking at the disc, okay? So normally just outside the disc, then you will see the normal retina. But over here, you can see that there are these dark cracks which look like they're radiating out from the disc, and those are called angioid streaks. Very often, where the cracks are, you can have some neovascular membranes or bleeds. So that's why you can have some hemorrhages just at the edge of the cracks from the vessels in the choroid. These patients would have systemic things that you could see as well. So obviously, if a patient has got Ehlers-Danlos, they may have like hypermobility. If they've got pseudoxanthoma elasticum, they can have chicken skin uh, and kidney and heart related conditions as well. Uh, so, and obviously, I'm not going to go into systemic conditions because you all know that better than me. But this is what angioid streaks would look like if you looked at it on the direct ophthalmoscope. Anything else? You're welcome. But yeah, I would focus more on diabetic retinopathy, hypertensive retinopathy, uh, things like that, which are very common, and disc edema, disc swelling, which you all are more likely to get in your exam. Yep. And if you'll have any questions, you can always, get in touch. I'm happy to answer them. You can just direct them to Shoaib and he can redirect them to me. I will send you all a little feedback form just because I want to know how I could make this better and more useful for you all. I hope you'll have found it useful. I hope you'll have got at least a little bit of something to help you with your exams. All the best. But just remember, please go and just use an ophthalmoscope. It hardly takes 5 or 10 minutes, but just get familiar with it because I think that's very important in an OSCE exam, is to just at least appear to know what you're doing. I didn't say that. Okay. All right. So if we don't have any more questions, I am going to end the meeting. Yep. Thank you. Have a good weekend, everybody, and all the best for your exams. Bye-bye.